Perfect. Well, thank you. Good evening, everybody, and welcome to tonight's education session, which is on occupational dust exposures, specifically looking at clinical pathways for silicosis and dust disease in South Australia. I would like to acknowledge and thank South Australian Mining and Quarry Occupational Health and Safety Committee for supporting this education session tonight. So before we begin, I would like to commence with an acknowledgement to country. We would like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay respect to their physical and spiritual connection to land, waters, and community, enduring now as it has been throughout time. We pay respect to them, their culture, and to elders past, present, and emerging. So just a few housekeeping points before we start. We would like to keep tonight's education session as an interactive session. So if you do have questions, those in the room, just raise your hands and we'll come around with the mic. Those who are joining us online tonight, please enter your questions into the Q&A and they will be read out to the speakers and the panel for you. There is an evaluation form. Those in the room, it's on the table, and those joining us online, it will automatically pop up on screen when you exit the session tonight. And for the RSEGP and ACRIM members, the education tonight is accredited, and your CPD points will be automatically allocated to you at the end of the by the end of this week. And statements of attendance will also be circulated. We do ask that you please keep your phones on silent during the workshop. And for those in the room, if you do need the bathroom, it's through the back door, just to the left there. And so introducing our speakers tonight, we have Associate Professor Sharon Gaskin, who's an Associate Professor in the School of Public Health, Environmental and Occupational Health Sciences. She's also the Director of Adelaide Exposure Science and Health Laboratory, and she'll be presenting to us tonight on general information on occupational exposures measured in South Australian industries, specifically in the construction, mining and engineered stone industry. Our second speaker for tonight is Professor Hubertus Jersman, who's a senior respiratory consultant at the Royal Adelaide Hospital, and he will be providing a presentation on clinical information on case identification, early diagnosis, investigations, and monitoring. And our third speaker for tonight is Crystal McBride, who's a technical advisor at Return to Work SA, and will be speaking to you tonight about the compensation pathways. And with that, I would like to hand over to Professor Gaskin.
Great. Thank you, Helen. Welcome everyone in the room and to all of those of you who are joining us online. So just by way of a bit of a background, I guess my main area is around primary prevention of lung disease. I've been working, I guess, for about 15 or so years, trying to understand exposures in industry and trying to help implement practical solutions to prevent that exposure. So I'll stick to that lane as much as I can in today's presentation. And I'd just briefly like to acknowledge and thank Hridita Ahmed from Macquarie who helped prepare some of these slides today. I always like to start with the end in case you need a break or a nod off. So my take-home messages from my part of this first part of the presentations this evening is really to drive home that we do have workers being exposed to crystalline silica and often overexposed in a range of different industries, and we'll cover a number of those high-risk industries broadly today. And secondarily to that, we may well have illness and disease in these workers, and we simply don't know the extent to which that is the case. So they're the main sort of exposure positions that we find ourselves in that we like you to be mindful of. But let's start with the industry of mining and quarrying. I guess it's the most familiar and long-standing dust disease kind of industry. Part of what we understand about exposure to crystalline silica is dependent on the materials themselves that they're mining, extracting. And in terms of mining and quarrying, in South Australia, we do have quarries that are for sandstone, quartzite, aggregates, and all of those by composition, minerally, contain high levels of crystalline silica. So it's part of the conversation is what are they actually mining and where's the source of silica, but it's equally about exposure to those materials and the interaction at that interface. So to give some idea around exposures, when we talk about high exposure to crystalline silica in the mining and quarrying, you can see some of these images here around tasks. So what we need to understand is not just the material itself, but how the worker may interact with that material when it's in a dust form. Obviously, you can see the difference between perhaps large-scale industry like this. Those are workers that are in bulldozers or excavators may well be in an air-conditioned, well-sealed cabin, and their exposure to the dust may well be very different to the workers that are in the crusher or maintenance or those that are roaming around on site. But ultimately, it's important for us to understand not just the material, but the way in which the worker is exposed to the emissions that are from blasting and other activities with that material. So when we start to look at, well, how much is too much and how many and who are overexposed, this table gives a little bit of an understanding of the different types of roles in this particular occupational groups and understanding, well, where is the evidence to show what they're exposed to and when and how much they're overexposed. So when we look at exceedances for the workplace exposure limit, and we break that down into what we call similar exposure groups. So these are the roles, tasks, jobs, if you like, within the mining and quarrying context that are where we're seeing overexposures to crystalline silica. So as I said, you can see at the top of the list, there are those workers that are more mobile, workers such as crusher operators, maintenance workers. They're more often having overexposures than perhaps some of the others that are in excavators, dump trucks, and in air-conditioned cabins. So that tells us a little bit about not just industry that are high risk for exposure, but within industry, the different particular workers that are at higher risk of exposure. And there's evidence to show that's actually occurring. So most recently, Macquarie have undertaken their annual monitoring. So this is monitors that are worn by workers, or their personal monitors for their workday. And we look at, well, what proportion of those workers are overexposed. We can see that something like 57% are compliant with the current workplace exposure limit, but there are also a large proportion of workers which are either exceeding the limit, which is the darker brown wedge, or at 50% of that limit. And we call that an action limit. So it means you still have to do something about reducing exposure for those segments. So we're still seeing in this industry, we've known a long time that it's a problem, dust is a problem. We're still seeing non-compliance and overexposures in this particular cohort. This translates into latest Safe Work SA, the regulator, issuing notices, improvement notices, for this type of industry. These are the latest data from 2021. And what they're getting improvement notices for is that they're not conducting air monitoring. So even the data that we have around overexposures are likely to be the tip of the iceberg in terms of many are simply not monitoring at all, so we don't know their exposures or how frequently they're overexposed. The second thing that they're also not doing is really implementing controls efficiently. And so the industry has been put on notice to make changes in that regard. And this is a well-resourced, big industry, lots of finances to be able to put good practice in place, and we're still seeing non-compliance. So we've heard a lot in the media, I guess. Engineered stone has been an emerging issue for a number of years. I first started looking at this industry in 2018, others in the room and in the state. What about exposures in this context? This is not an unusual image of the sorts of workplaces that we have been to. What you can see is it's not a highly sophisticated kind of environment like some of the mining and quarrying operations, often large sheds. They have the kitchen benchtops on trolleys, and they're using simple angle grinders and hard tools to cut out sinkholes, tap holes. Ventilation is essentially an open roller door. Occasionally you might see is in the top corner some extraction fans in inverted commas. Largely that just pulls air around, and you can see that housekeeping is not a main priority for a lot of these places, and that's just going to essentially resuspend the dust into the air column and the breathing zone. I guess what we're saying in this regard is, unlike similar exposure groups or particular work roles that we see in other industries, doesn't really apply here. It's a shed. Whether you're actually grinding it or just walking past it, you're going to get a dose of the dust. So all engineered stone workers would be exposed in this sort of construction scenario. But it's not just about the factories and the fabrication environment. It's also about those that have to go out to homes and businesses and construction sites and actually put in the engineered stone slabs in the kitchen or bathroom or wherever it might be. As we know, the best laid plans with the best measurements, you get it out to site. Walls are never plumb. It always needs a little bit of tweaking here and there, and they just simply don't have the requirement that they have, or the tools and experience and the kit to be able to do that safely in someone's home. So they'll often do what they need to do to get it done. I think the main take home I want to say about this is think about proximity to the emission source. So again, engineered stone, just like sandstone, is about 90+% crystalline silica in terms of its composition, but your exposure to the dust from it for an installer in engineered stone compared to an excavator in quarrying, same material, very different exposures. These guys get very up close and personal with this particular material, as you can see in these images, and their exposures are high, brief and very high typically. And I know that they're wearing respiratory protection, but not all that is equal, and they're often just shaking it out from the back of their ute before they're putting it on. So we need to understand proximity to the dust source as an understanding of the exposure, and it's not just about the materials. I know that we talked about when we were talking about prohibition, there was a lot of conversation with us around, well, why do we have to ban it all? Maybe we'll just reduce the amount of silica in a material. At the end of the day, there really isn't the evidence there to suggest a safe, unsafe line in the sand, because it's not just about the composition of the material, it's about the proximity of exposure to that dust cloud. And that's why it matters in this space. So when, again, we look at notifications in this industry, a notice is not just to improve, but also to completely prohibit. So a prohibition notice means, stop work, down tools, close the door until you fix things. But again, what we're seeing in this space is they're not conducting the air monitoring, they're not reducing the risk of exposure. And at the very bottom, you'll see cleaning, the forgotten workforce in terms of risk in many cases is no exception in this industry. The poor cleaner who comes along, and let's face it, cleaning doesn't happen daily, probably not weekly, maybe monthly. Those floors are pretty dusty. And maybe it's best to wet wash and sweep, but let's face it, it's quicker to get a high pressure air compressed gun and just blow it all out the doors. So don't forget that risk doesn't necessarily mean you're cutting and grinding. It could just be that you're in housekeeping. Not to forget monumental stone. So this is traditional stonemasonry. We're talking headstones, monument works. These we've known about forever, and we're still seeing non-compliance in this space. We're still seeing lack of air monitoring for these workers to understand their exposure. But again, they're up close and personal, and there are fewer of them in the industry, but it's still something to be considering in terms of exposure of importance. I won't go too much into detail about this slide, except to say in 2019, we looked at those similar exposure groups as part of our silicosis health screening program. Hubertus may spend some more time looking at this. But essentially, we can, in the first column, you can see the different tasks, roles, groups, if you like, and then you can see of those with possible, probable, or confirmed simple silicosis. A large proportion are able to be understood in roles that we know are high exposure. So installers is number 2, for example. So we're seeing disease in those that are highly exposed groups. And the further down the list you get, the more likely they are to have a reduced exposure because of engineering controls or other interface between the dust emissions and their breathing zone. I know that Hubertus will go into this more detail, but basically the baseline findings from this initial screening program was that of the 50% of the workers who were diagnosed with possible, probable or confirmed simple silicosis reported being exposed to cutting and grinding engineered stone. And of those, 90% admitted to having done dry processing, and all of those said for more than 3 years. So we're talking significant prolonged exposures here. But what about construction? It's a really important next big cohort in many cases. I think it's not uncommon for us to simply drive down any street in Adelaide and see an image like the one centre where you've got a worker bent over with a diamond blade, quick cutting concrete, no hearing protection, no breast mask, maybe a weak little dribble of water from a hose. But there are other tasks and groups within this industry where high exposures to crystalline silica occur. It can be large scale, tunnelling, and also sandblasting, or it can be smaller scale construction like cutting and polishing concrete. These are all also high risk. And also a little bit more mobile in a lot of these cases, sole traders, workers that are out being hire labour company provided to sites, not necessarily within a particular site and able to be captured for air monitoring. What are their exposures? We actually know a little less about this cohort. Far fewer of them do any monitoring, air monitoring or health for that matter. But for what we do know, we know that the general construction worker is often, on average, overexposed. So we've got a workplace exposure limit, which the concentration shown on the screen. They're overexposed typically. Plumbers come off a little better in terms of those that do electronic maintenance, and theirs is slightly lower in terms of their average exposures. But tunnellers, you're getting an order of magnitude more often than not above the exposure standard in terms of their particular tasks within the construction industry. And abrasing blasting is probably considered the highest risk, where we're getting orders of magnitude above the exposure standard repeatedly. So there is that sort of difference again within construction. Not all construction is equal in terms of exposure, and understanding a little bit about task and role can also help determine their exposure, high risk or otherwise. In addition to, as I said, for the previous industries, there's been improvement notices in construction as well. In fact, of those that participated in this silicosis health screening program, 28% of them that had resulting possible, probable or confirmed silicosis were actually long-term construction workers, and a couple of them were actually concrete workers. So concrete has a lower silica level, but obviously their exposure is repeated and high. I know that Hubertus will cover this in a little bit more detail, but what does this mean in terms of claims? Well, since 2019, Macquarie have paid for health screening for more than 500 workers in South Australia, and we've had 21 silicosis claims since then. 12 of those have been accepted. And in terms of who, we're talking, there's a male-dominated industries here. 71% of them were over the age of 50. So that's in terms of who is being diagnosed with disease across the board in South Australia. Might be a little bit different in Queensland, New South Wales with more cases of younger engineered stone workers, but that's where it is in terms of ours. So my last slide, I'm doing okay. I guess going back to my take-home messages, there is exposure, often overexposure and across a range of different industries, and not all tasks, workers, roles within an industry is the same. So understanding a little bit about who the worker are and what they do and how close they are to an emission, irrespective of whether they wear a mask or not, because that shouldn't be a factor really, because they fail basically. At the end of the day, there are laws in this space, and work health and safety laws require, that's a must, not a should, that high-risk industries with exposure undertake health monitoring. And so that's where my lane deviates, and I will then hand over to Professor Jersman to talk from more of the clinical pathways. Thank you. Thanks, Hubertus.
Thank you. There might be a little bit of overlap still, but it doesn't matter. Redundancy is good. Remember more. Yes. And what you said reminds me of my own kitchen. The people came in, typical Aussie workmanship. The thing didn't work, carried in the garden, grind it down 3 times, each time no mask, big cloud of dust. And when I said to them, is that a good idea to breathe in the dust? I said, no worries, mate. And that's the problem. Yeah. How do you do the slides? Like that. Okay. Good. Let's start my talk. It's a bit of whenever a German talks, there will be philosophy in there as well. Politics and philosophy. I can't leave that out. It's also a big picture and a bit of exposure, and also what the disease is like. So this is our planet, volcanic activity, sand, dust, and what you should realize that nearly 60% of our planet's crust is silica. So even if there's a ban on artificial stone, we will never avoid being exposed to silica, working with silica. And that's an important theme that will go through the talk. It comes, we're talking about crystalline stone, quartz, marble, and so on, lava, not the amorphous one in wool insulation. Now that's important to bear in mind how much silica is on that planet. So there's a history, and my university teachers were as old-fashioned as me, and they taught me that if you don't learn about history, you're going to repeat the mistakes or repeat the history. We see that with Trump at the moment, but in many other ways, you shouldn't repeat history, and the first step is to actually know the history. So there are historical descriptions of silica damage to people from the 1500s, 1600, 1700, and the middle of the slide shows the more recent ones, the famous Hawker's Nest tunnel. 764 people died because they were exposed and not wearing protection. The slate pencil workers in India, the real numbers are a bit sort of obscure and covered up, but it's still going on. The denim sandblasting, when I was little, there was a ABBA, and all these other people, and the Beatles, ABBA, and after that came the flare. I got rid of my last flare pants a few years ago. I should have kept it for dress up. Anyway, and then there was a fashion that the jeans shouldn't be blue, the blue jeans. They had to look like they were washed 150 times. And the way that was done, they used fine silica dust and sand and blasted them without any regard who actually blasted them. I'll show you a slide in a minute. And then from 2009 onwards, this new invention came along in Spain, and then shortly after Israel, artificial stone, brand new. And sure enough, in Cadiz, in Spain, were very soon after were the first cases. One mortality, a few sick, and no one really clicked, and no one looked there, because we're here in the penal colony on the other side of the planet. Yeah. No one really looked what's going on, and the stone was suddenly here, and then surprise, surprise, now we have the problems. South Africa, of course, the standard mining, digging for gold. There's a bit more silica in bedrock. If you look at normal mining, North America, Europe, the bedrock silica content was about 3–4%. Miners still got silicosis, but it was very slow and long-standing and so on. 3 to 4%. The stones, as Sharon already said, over 90%. Huge different exposure. The rock is just rock, whereas the stone has resin and metal ions and other things in it as well. So it's a huge difference. And even in those classic industries, it already caused silicosis. And the interesting bit for me, for example, in America, there was an increase in miner silicosis. The reason is the mines are exhausting. So they need to dig through more rock and have less coal and more rock. So they have up to 6–7% silica. So they have more silicosis than before when it's only 3 to 4. And that is already a signal that you can see. And obviously with this artificial stone, there's a lot of signal. These are the genes, what they look like when they're sandblasted. I had them myself. I'm guilty when I was in Europe still. You've seen that slide, but I just want to show it again to point out that you can ban artificial stone, but you can't ban sandstone. And there's a lot of work done with sandstone, and there is silica there. And my biggest fear about the ban, although I support the ban, my fear is that people hear about the ban and say, yay, we won. we can take the mask off, we can let the guard down, the bad stuff is gone. But 40% bad or 90% bad in another stone is still bad. So it's really important. The message is that we mustn't let our guard down, ban or not ban, we're still working with silica, and someone will demolish those houses with an artificial stone in there. So there will always be exposure. So the workers have to be really alert, educating the workers and staff around it, like the cleaning ladies and the apprentices, using masks and so on. Really important. That's a recurrent theme of this talk. And I feel good. My main kitchen bench is actually marble, although my wife had to sign a form. It's a stupid idea to have marble because you get dents in it and white wine and vinegar burns it. Anyway, but that is only 2% silica. And so that can be demolished without much morbidity. This is a photo of these stones. That's why they're so attractive. They're hard. You can put hot pots on them. They come in all sorts of colors. Bottom left, the really dateable, kitschy ones, but sometimes just plain white or fake marble. So you can just see the attraction that came with all these stones. There are some papers that looked at how much dust actually gets generated. 30 minutes of dry cutting is 400 times the 8-hour, which is a working day, limit for Australian stone workers. Wet cutting, proper wet cutting, not the odd hose, but like a dentist drill. I had that last week, where the water constantly jets, remakes it into a slurry. The slurry then runs on the floor into a pit. When I ask the screening workers, when I screen them, what happens with that, some don't know, and some say, oh, someone takes it away. And I never found out where it's going to take it away and whether it dries there and gets blown around somewhere. Maybe you can enlighten us later during question time. But if it's 10 times better, 400 times the exposure, then 10 times better still means 40 times the exposure. So this is not really harmless just to put some water on there. It's relatively better. It's a bit like vaping and smoking. It's all bad news, but one is relatively maybe better than the other. And this is such an instrument that adds a water jet to the cutting. So what is actually silicosis? Wikipedia helps. Even doctors use a lot of Wikipedia. So it's basically a type of lung fibrosis. You breathe small particles of silica. Anything less than 10 micrometers goes into the lung. The asthma puffer Ventolin, for example, is 2.5 micrometers. Some of the dust is actually smaller, and it gets right down to the bottom of the lung. That's why Ventolin is engineered to be 2.5 micron. And cyclazonide, as you know, 0.9 micron, so it definitely gets deep into the lung. And it's a common mineral, as I said already. You can't avoid it, really. So over time, it's a response of the host, it's the dose, it's the form. Dry cutting is more aggressive, the crystals. The combination of that is cumulative during a lifetime. This goes into the lung and eventually causes so much inflammation that scarring occurs. Shrinking, thickening, and then you can't, it's a double whammy. One, you can't, when you breathe in, the lung doesn't expand as much. The second bit is, if the fine membranes in there thicken, the diffusing capacity drops, the oxygen doesn't get through the wall, and when you breathe out, too much oxygen comes back out again without being utilized. And interesting, in the early parts of last century, the Americans are a bit flowery with the word. Sometimes they labeled that the king of occupational diseases because it was so dangerous and so common, and we've forgotten all about it. That was 110 years ago. But Americans are like that, the mother of all bombs and the mother of all wars and the king of all diseases. Well, it highlights to you that this is not a new problem. We just conveniently somehow forgot about it. So there's a lot to say about how much has to go into alveolar space, 1 to 2 grams. This is all a bit guesswork, and there's also susceptibility there, as I said before, of the people. When they cause irritation of the tissue, some elements get released called reactive oxygen species that are the immune cells. It's almost like pepper spray by police, or pepper spray in your handbag. So it causes us non-specific inflammation, and all the cells keep running to help with that inflammation, like an army of cells, and it goes on and on and on. Yeah? And when it's visible, and it has to be a millimeter, half a millimeter at least or more, when it's visible on some CAT scan, you have little nodules. Yeah? And then you get confluent nodules, and I'll show you pictures in a minute, so large bits of the lung. Convalescent lung gets smaller and the breathing gets worse. Yeah? And then you have a diffuse silicoproteinosis. This is a picture for the visual learners. This is some biology textbook, what the silica does in the bronchiole and the alveolar. All the cells, the yellow ones are the macrophages. So the immune cells, they think it's some kind of intruder, and if it's a bacterium, the cells come up and eat it. But with the silica crystals or asbestos fibers and all these inorganic things, the cells eat it, but either have severe indigestion or die from that. And then the next cell eats the debris and dies from that, and so on. So that's where the inflammation comes from. It's not really digestible. And you can see from calcifications in people's lymph nodes, I'll show you a picture in a minute, that this stone-like thing is there forever. It's actually deposited in the lung. Now, the first case report, I said earlier, 2009 in Spain, then 12 in Israel. If you look at the, we now have 2024. So why did no one cotton onto this much earlier? How come? Yeah, I mean, the scientists did, but the politicians or regulators didn't. Yeah, and if you compare to the traditional silicosis, by that I mean, I'm from a mining town near Dortmund in Germany. Yeah. My lung function is reduced because I lived next to a mine and a cokery. Yeah. But not silica, just the other toxins. And it's much more severe because you need less exposure, relatively, because it's so highly intense, 96%. Yeah? And then the patients become more symptomatic and are rapidly progressive. And I have a few patients myself. One lost half of the lung function in 9 months. This is rapid. And when all our guidelines, when you look at the guidelines, I'll come back in 5 years and stuff like that, that's for mining. When they breathed in some bits of the dust, that was at max 3%. We don't really know. And we're learning it now the hard way, what 95% plus resin, plus iron, metal ions, what it all does. We're learning on the fly because this is a new territory for us. And it's also, which we didn't realize before, so much is associated with immune disease. I've got one patient presenting with lupus, and everyone said it's nothing to do with silica because they hadn't read that paper. It's actually associated with autoimmune disease and other things. And this is too busy to read the whole thing, but this is country of the study and how you just look at the right, how many people, initially only maybe 200 people or 300, but their age. Yeah? Normal silicosis is not 33, it's not 44. We had 3 people die in New South Wales and Queensland 2 years ago before they could even be on the transplant list so quickly. They had little kids, rapid progressive. We're not used to that because our minor silicosis is much slower. This is a real case. So the normal X-ray is on the left, and that's reported as normal, but no CT was done. And the CT is much finer a tool than a chest X-ray. And the second X-ray was done and surprisingly reported as normal. But even, I hope that even you can see that this is not quite normal there, this area, compared to here. There's something going on. And then lost to follow-up, came a little bit later, and then the whole right side was shriveled up. And then someone did a CT. And on the CT scan, which is a much finer tool, we use high resolution CT scan. And if you're not worried about other structures and clots, you can just use no contrast and even low radiation. Like the next year when it comes for lung cancer screening, we can use those sort of technology. Much, much better. And for a quickly developing disease, I prefer CT scan. So you see here, the typical silicosis distribution, unlike other fibrosis, is not the bottom of the lung. You listen at the bottom, have crackles. This is the top of the lung. Whereas we often get cases in the Royal Adelaide where someone had some gallbladder problems or maybe perforated ulcer, something like that, and they had a tummy CT, and the bottom third of the lung is on there. And then they say, oh, it's fibrosis. And we work them up and they have a bit of fibrosis. But with silicosis, that trick doesn't work because, and this person that one of my patients actually had lots of apto-CTs. And he took comfort from the fact that the bit of lung that was visible was actually normal. But no one did a chest CT because the silicosis in the top third of the lung was always missed. And here you see it. And on the bottom right is the bottom of the lung, or fairly much towards the bottom, and that looks normal. But the top is shot. And on an X-ray, it looked moderately bad, but not that bad. But on CT, it's really bad. And the left side doesn't look that bad. With hindsight, you can see something. But here on the CAT scan, it's quite obvious that the left side is also not normal. Because when you breathe, you can't say only one side, please. This is a more advanced case from a publication. And at the bottom left, in the middle, you see all these white things, and they are the famous eggshell calcifications. These are the lymph nodes, because all the immune cells that eat stone need to go somewhere. So they go to their depot, and their depot are lymph nodes. They're lymph cells, they go to the lymph nodes. And in there sit, accumulate the metal, and it's looking like eggshell. Pathologists and radiologists always use food to describe pathology. It can be off-putting for some people. So eggshell lymph nodes. And we do a new technique at the Royal Adelaide where we have a bronchoscope with a needle attached and an ultrasound probe to guide us, and then we ram a needle into a lymph node to sample it. It's called endobronchial ultrasound with needle biopsy. And it's so typical. If some patient comes to me and they say it's probably cancer, so I look at that, see this, and I think, oh, it sounds like dust to me. And we stick the needle in and it bounces off the lymph node. It doesn't go in. It bounces off like you want to puncture a cricket ball. And that means silicosis, basically. And when you get a bit of tissue out, the pathologist anthracosilicotic material. Surprise, surprise. So it's, you don't really need that procedure to diagnose silicosis. You need a CT. CT and lung function, you don't need the biopsy. But the biopsy was done in these cases because someone said, I think it's cancer. Please tell me the opposite. And this is, unfortunately, this young radiologist died now of her cancer herself, but she was very passionate. And I just picked out one random report, if you read that. So she becomes very emotional. Normally, radiology reports are not emotional. That is very boring and often misleading. Sorry, I didn't say that. But this is very, very emotional. So several workers already had a 3-month review and lost 15% of the lung function within 3 months. That's exactly what we are seeing. And that made her emotional, and sometimes makes me emotional as well. So just a reminder of these associated conditions. TB is a long history of being associated for minors, but there's an overlap because TB is also a disease of poverty and overcrowding. And the minors in Europe were often the poorest ones, and they shared 4 people in a bedroom in a house, so they could get TB much more easily and spread it around than other people. But it seems to be linked from lots of research papers to silicosis itself. More lung infections, funny ones, autoimmune diseases we talked about, lots of them, but also lung cancer and other cancers, and chronic kidney disease, believe it or not. So it is, you need to look widely when you have a patient like that. And any other disease, of course, will affect the ability to transplant them, because if they have lots of other problems, especially scleroderma, the transplant team don't want them. You've seen the slide already. It started off, just look at the left. You have seen the table on the right. When they first screened people in Queensland, just under 800, 12% had the disease, 2% were massive, which is sort of rapidly progressive and end stage. You've seen that? Yeah, so high-risk industries, whoever defines that, maybe return to work, Australia defines that, or whoever, they require health monitoring under work health and safety laws. And maybe we can discuss at question time what we do if, despite the law, a worker says, bugger off, I'm not getting screened. If that ever happens, what do we do then? That should be maybe brought up in question time. Yeah. So health monitoring, this is the law. It's required when there's ongoing significant risk, and this is most of the industries we talked about. It must be conducted by a suitable medical practitioner like you or me, or who defines suitable. That's interesting. There's obviously an overlap in specialty between occupational medicine and respiratory medicine. It involves monitoring and testing and identify changes to workers' health. Yeah. We come to what we do in a minute. Yeah. And then the funding, who pays for the health monitoring and informs the workers and so on. Yeah. We can maybe talk about afterwards how that actually plays out in this state. So the report needs to go to the patient, and we write a letter that the patient and the GP can see. But if currently I'm not sending it to the employer, but if we send one to the employer, it should be a report of the nature silicosis present or silicosis not present. I don't want them to know patients' private information, all the other stuff they have, from cholesterol to ex-smoking and so on. That goes in the GP letter. And then I hit a barrier when I started screening last year or the year before, that 80% of these young people say, GP, what's that? I don't have one. They didn't have a GP. Yeah. Why not? Oh, they don't bulk bill anymore. No, I'm just making that up. we need to entice those workers to see a GP. They must have a GP, and where do we start? We can't force them. Yeah, but that's the first problem. If a GP is a key player in this whole health management and they don't have one, they don't want one, what do we do then? Yeah. Yes. And must be kept for 30 years. That's beyond my retirement, I hope. Who knows? With daughters at uni. Yeah. So this is what we do. We conduct a doctor interview, break down barriers and relax them. And then we do a physical exam as well. And then have a range of questionnaires, one pertaining to their workplace and their demographics, one to their work practices, what do they actually do. And some do installing 1 day a week and blasting another day and so on. So you need to be meticulous. And where it becomes really hairy is if they say, oh, this is my 7th workplace doc, and they've already worked in Perth and Melbourne and now Adelaide in 3 different firms here. So it becomes a bit difficult. And I guess in the law, it will also become difficult. Then the lawyers want to assign percentages of damage and guilt and whatever. It must be hard. But some of them are only at one employer. Then we do testing. And this is not just spirometry. We measure diffusing capacity as well, and at least the baseline lung volume to see, because the volume of the lung is important. It shrinks later on if they get disease. And the normal range, pardon me, is so huge. From a fictitious normal 100%, it goes down plus minus 20. So the normal range, 80 to 120, you can't rely on. So you can have a worker with 100% or 90%. You can call them normal if you look at the normal range. But if you knew that when they left school, they had 130%, they lost a lot of lung. And also this high resolution CT chest, which has replaced the chest X-ray. And there's now also a well-published algorithm that expert radiologists use a technique which is similar to B reading, dust diseases scrutiny of a chest X-ray, which is now available in CT analysis. The big problem is that if some naive, Stone disease naive person does a CT scan and finds one basal nodule and makes it in the report, makes it sound like this is silicosis, the worker will be scared that they lose their job. The employer, if he ever gets wind of that, thinks that's early silicosis because they don't know it has to be at the top of the lung, and then wants to sack the worker. So you can do a lot of damage by doing the better test and doing by the wrong person and getting the report out done wrongly in the wrong hands. So it's really important that you settle on a few radiologists that upskill themselves, and maybe even have an MDM in each state. That's what we're trying to work on, a multidisciplinary meeting where radiologists and different specialists discuss borderline cases. Do you call that silicosis or maybe not? Because this is new territory. We need that kind of touch base before we release just a letter saying this is silicosis. And I re-screened a few from a few years back. They were labeled silicosis, but they didn't have it. Lucky for them. Yeah, so the big question, and we are really almost as scientific as this, yeah, when do we screen them again? So the current sort of, you have to start somewhere. So we're making up to say stone, engineered stone, 1 year. This is for people who have nothing wrong, right? They're screened and they don't yield any bad result. Then you do it more often. But if they're normal, you say engineered stone, another year, mining quarry, 5 years. Construction, sanding, cutting, 5 years. But this are sort of made up figures, but we have to have something. You know? And that's sort of level F, like Fred told me, arrived by experts over a glass of Henschke, Seal of Grace. Yeah? But it's still expert evidence, better than no evidence. It's not strong evidence. So the challenges that we sort of face when we tackle this whole business is, one, how do we find cases, identify all the industry and people? You mentioned headstone companies for cemeteries. There are bench tops made for kitchens, for bathrooms, for laundry, and for doctors' surgeries at the reception desk, in the doctor's nurse's kitchen. You know, the bench tops are made for everything. And then who captures all these people? I live in the Council of Burnside area, and I cycle to work, and I see this guy cutting through the gutter, replacing the gutter, in a cloud of dust, cigarette hanging out of the corner of the mouth, no mask, not even a paper mask. Huh? I mean, how do you capture these people and bring them into health screening? And we don't even know how many days a year they do this kind of thing. So we don't know, with the legal term high-risk industry, is this a high-risk industry or not? It should be. So there's a lot of gray there. How do we identify all these people? How many people are there? We need to know that, and also for resource planning. Because if a busy health system has to cope with 150 people or 900 people, that makes a big difference. Funding, who's paying for all that? I'll leave that for you to discuss. And how about workers who are retired? So we've just cottoned on how bad silica is. And there may be a lot of stone workers that retired 2 months ago, or during COVID, or next month. And they haven't been screened yet. So how do they get their health checks? Those ex-workers. The next thing is more for the doctors, finding something else. Yeah? We found sarcoidosis in patients. We found asthma in the lung function. New asthma, are we then the ones who prescribe the puffer? Yeah? And so on. So there are issues. Liver, we found something in the liver because the chest CT scan goes down to the liver. Yeah? So we're finding things, and then we can't sort of say, sorry, I shouldn't have seen this. You can't unsee it. So you found it, but I'm not a gastro person. I'm not a hepatologist, but you have to channel them somewhere. And that should be the GP who then reacts to it. But 80% of mine didn't have a GP. Yeah? So we have a bit of a dilemma. If we find something else, how on earth get that all tidied up? And the best person is the family doctor. And if they don't have one, and what can we do? And then the implications of finding it. How much is too much? Do you say it's a little bit of silicosis, you can still work, maybe do some different work, become an instructor rather than a cutter? Yeah? It's hard, but ideally, if your lung is affected and you're in a dust industry, you shouldn't work in a dust industry. We had a few workers that completely retrained, youth worker, health educator, all this sort of other jobs, fitness coach even. Yeah. Yeah, the barriers are the fear. So some workers cancel their screening because they Google it, or the last minute they realize, oh, if the doctor finds it, I'm done for. I lose my Commodore and my mortgage and whatever. I've got no other skills. So there's a lot of fear for the unknown, fear of the testing, fear of the result. of the testing, and the compliance we talked about, and the practicalities. Do you bring someone down from Roxby Downs or Ceduna or Whyalla or Mount Gambier? You can't bring them to Adelaide several times. So that's what I mean by practicalities. And there's some new plan to have a mobile bus equipped with CT scan and lung function and doctor rolling around. Sounds like an election campaign. So this is new. So suddenly, after many years of bad planning and bad implication, suddenly we have a natural registry. No one from the Thoracic Society or Lung Foundation has been involved in this. And we've just been told it starts in May. And we heard on the grapevine that if a doctor doesn't report, there will be a $40,000 fine. They haven't confirmed that yet. And this is a great idea to entice doctors into screening patients, because they will all run a mile and say, dust? No, I'm seeing the one with asthma. So this is a really bad idea. Let's see how it pans out. They want to start it in May, and we haven't seen the details. It's quite amazing. And also registry, they kept saying in their flyers how easy it is to do. The last one that they had was several pages long, and I would have had, in my 20-minute consultation, I would have had another 35 minutes entering the data, because when I was born, everything was made of wood, and I typed with 2 fingers. Yeah? And even my watch is wood. So this is unknown. How easy will this be? Yeah? And how heavy is the penalty if we forget one? Yeah, so let's talk about what we do if someone has silicosis. Yeah? Because the treatment isn't very great, I'm trying to tell you. So avoiding the exposure is absolute key. Then we have a bit of anti-scarring medication. We'll come to that in a minute. There is this very controversial total lung lavage. You probably had heard of that in the news. And there is lung transplantation, which is not an end-all to everything. It's a palliative procedure. The average survival after lung trans is 7 years. So if you are 70, that's fine. Well, maybe 70-year-old doesn't think so. But if you're 33, that's not fine. You have little kids in primary school. Now, to the exposure and avoidance of exposure with a mask, how do we play the video? Is it playing automatically?
To make sure it would fit various kinds and sizes of faces, it had to form a dust-tight seal on all types.
Eric.
The long and narrow, the medium, the round and full. To test security of fit, coal dust was blown into the air. They breathe deeply, trying to suck in all the dust they can. When the respirators are removed, the sharp white line must show not a sign of leakage around the facepiece. His face is dirty, but his lungs are clean.
The fanfare is so typical American 30s, King Kong and so on. But it's pretty obvious that they realized 100 years ago that you mustn't breathe in the dust. When you see the people coming for screening, it says in the guidelines, P2 mask, clean shaven, and they come with a goatee or stubbles or full beard. And you can tell it's not just 24 hours. What can you do? Can return to work as a enforced shaving? Do you bring a shaver to your site visits? Electric or wet? Yeah. So there are these medicines that stop fibrosis and healing, because fibrosis is often too much healing when you don't need healing. And silica has a different cause for that, but the other diseases have it spontaneously. So the only drug currently in Australia that is licensed for use in progressive fibrosis, even if it's from silica, it's nintedanib. It's 150 milligrams twice a day. It causes a lot of diarrhea. So it's, and at best, on average from the papers, it slows down disease progression on average by 50%. That means in some people 100% and some not at all, but on average 50%. So it's not a miracle drug, not a magic gun, but it's the only thing we have. This is the paper. Athol Wells from London, big guns on that paper. The inbuilt trial, published 4 years ago in the New England Journal, and we can use that now. It took a while for Australia to accept that, and now it's on PBS. Yes, so the 6 cases in Queensland, they got a lung lavage. What lung lavage means, you give them a general anesthetic, you put a tube in their trachea, it is split, not just one tube, it's separate, one for each lung. So when you do the right lung, you pour in saline and out again, 30 liters in and out. Then they spend some time in ICU. When they come back, the other side, 30 liters in and out. That's a lot. That only did 6 cases, and currently between Queensland and Melbourne, there is a trial enrolling to do this more often and do more data. The Chinese trial, they have problems with English, and I read the paper, but they had 70 patients, and in the discussion, there was suddenly 159. I don't know where the others came from, but they had 70, 35 got lavage, the others didn't. And then they said the ones that didn't have more asthma symptoms. They meant probably breathlessness. It was probably wrongly translated, but these are the only 2 papers in the world. So we can't say, tell all your patients to come and we wash out their lungs. They spend time in ICU, they haven't died from it yet, so there is not a harmless thing to have 2 GAs with 30 liters each. The report was surprising because if you think of silica that's there for several years, how can you possibly wash this out? I have my doubts. If it's fresh, there may be in alveolar macrophages dangling there and the fluid washes them out like a flood. In Queensland are good at floods. They have 300-year floods in the last 7 years. Yeah. It seems a little bit adventurous, so I don't think doctors can say this is our standard treatment at the moment. But it's worthwhile knowing that this is sort of being investigated, but it's a little bit adventurous, I would say. Brave. So this is my philosophy bit. So if I could talk to any of this, if I was part of Nemesis and could talk to these guys, I would say, man, before you allowed this stone into Australia, what testing did you actually perform? It's a rhetorical question. The definition of that is we know the answer, and there were basically nothing. Yeah. So now, big fanfare, we banned the artificial stone. Obviously, the industry will suddenly want to use ceramic stone or some alternative artificial things. They will use something as a replacement. And then my question again is, after having learned from history, after suffering all these problems, what testing are you going to perform before letting this in? Are you aware of any? Yeah, you're doing it to shame them. But officially it's Zipol or buggerall or whatever the Aussie term for that is. So not much. Yeah. And when you see all this, as a German, you can't help but saying, Scheiße. Yeah. And the Australians would say, bugger. They're doing it again. Whereas the English would say, disappointing. Yeah. And it is indeed disappointing. Yeah. So my summary, the last slide, is we did not learn from history, and we're still not learning from history. I hope I made that point. Yeah. The second point I hope I harped on about is we cannot avoid silica. The stone may be bad, but remember, sandstone, 90%, granite, concrete, 30, 40%. Silica will be there, so we can't give up on education and measures against silica just because the stone is being banned. Yeah. And the treatment is not good at the moment, nothing fantastic. We're trying what we can, but it's not curative, or we can't get the silica out really. So prevention and early looking for cases, avoiding further exposure and so on, that is the key. That's where the money is at the moment, and that's you need to find the money for. And the referral pathway, so I'll let the others talk about it, but from the slides before and what I've been told is either McQuash or Return to Work SA. And I don't have Crystal's mobile number or Sharon's mobile number. I'm sure they'll give it to you later on the next slides. How do you actually refer these cases? Now, if they have symptoms, This has occurred if a patient has symptoms, a cough, I can't breathe, we can treat them initially like a normal Medicare referral. We see them as a case. But if they don't have symptoms and come through screening, that's through you. But there's another group that hear on the news or on the internet or from a former workmate that they should be screened, but they're well. What do they do then? Do the GP send them in through Medicare, as happens in Melbourne? Or do they come through you? Maybe you can refer to that later. So I hope I stayed on time. Yeah. Good. This is a bit of sand, but on the beach. Yeah.